Good afternoon or good day to everyone. Good morning and good evening to some parts of the or some of our attendees. So for those of you who don't know me, I'm Irwin Tabu. I am the current chair of Ffn Philippines and the deputy chair of the Ffn Regionalization Committee. I'm also from an orthopedic surgeon from the Department of Orthopedics, University of Manila in the Philippines. So in today's meeting, we will be focusing on multidisciplinary management of acute fractures, and primarily on mapping pathways of care and getting quality data to improve patient clinical outcomes. And thus, we are collaborating also with the Ffn Hip Fracture Audit Special Interest Group. So to start our meeting, I would like to introduce one of my esteemed mentors and colleagues in orthopedic surgery. He is the past chairman of the University of the Philippines Department of Orthopedics, a member of the Senior Advisory Group of Ffn Philippines, and he's also the General Secretary of the ASEAN Orthopedic Association, and has been recently elected as the incoming first Vice President of the Asia Pacific Orthopedic Association. So, dear friends, I would like to introduce to you an avid supporter of the Fragility Fracture Network, Professor Ffn Pasion.
Thank you, Irwin, for the kind introduction. Very good afternoon, good morning, or even a good evening to everyone, wherever you are in this world. My special greetings to all the other leading and distinguished leaders of the FFM Global, Regional, and National. I would like to welcome you to this second Asia Pacific Virtual Pocket Meeting, hosted jointly by the Fragility Fracture Philippines and the University of the Philippines Manila, Philippine General Hospital Department of Orthopedics, which is celebrating her 50th founding anniversary this year. We are honored and privileged to have distinguished speakers from the FFM Global, the Asia Pacific region, as well as from the ASEAN region. They will give us updates on the multidisciplinary acute hip fracture management, mapping patient pathways care, hip fracture registry, and getting quality data in these registries to improve clinical outcomes for the elderly with the fragility fractures. In the second part of this webinar, we will hear from the invited national FFM leaders from the Asia Pacific region to present their respective hip fracture registry experience. This will be followed by a panel discussion among national representatives on how to further improve and utilize the collected data on hip registries. All of this is towards our realization of the goal and the theme, which is actually the development of the workforce in the Asia Pacific region in support of the World Health Organization Decade of Healthy Aging 2021 to 2030. I would like to congratulate the FFN Regionalization Committee, FFN Philippine board members, and the UP-PGH Department of Orthopedics for their untiring efforts in the preparation of this exciting and highly informative webinar. I hope that everyone will enjoy and learn from the webinar. Your active participation in the question and answer portion is very much encouraged and welcome. Thank you and mabuhay to all of you.
Thank you, Professor Pasion. So at this point, I would like to call on the chair of the Regionalization Committee and the founding president of the Fragility Fracture Network, Dave Marsh, to give us updates regarding the news about the FFN and the Global Congress. I'll just check if
David is still not logged in.
Okay. So on behalf of Professor David Marsh, I will be talking about the global update for this month about the happenings of the Fragility Fracture Network. Okay, so the Global Congress actually will be held on September 28 to 30. So what's unique about this Congress is that there's a combined pre-Congress regional meeting happening in the three regions of the world, namely the Asia Pacific region, Europe, and the Latin America. So the Global Congress will actually be hosted with an Eastern time. Supposedly, this was to be a face-to-face meeting hosted by our colleagues from Toronto. We are pleading to everybody, to support the Congress. If you love the FFN, if you like what we are doing, we are providing many free educational materials and webinars throughout the entire year, which are entirely free. No, however, to be able for us to sustain what we are providing the globe in terms of fragility fracture management care and education, we have to really promote this Congress, and your registration fees will come a long way in supporting the Fragility Fracture Network. Also, the submission for abstracts for e-posters was extended up to the 19th of July. So please, if you have any abstracts, submit this to the Ffn website, and your abstracts will be subsequently published in the Geriatric Orthopedic Surgery and Rehabilitation Journal. Also, those who will attend the meeting, the Global Congress, will also be involved in our General Assembly on the 30th of September, in which we will elect Ffn officers and board members. So at this point, we would just like to promote the clinical toolkits and the policy toolkits, which are all educational materials aimed to support the Ffn's global call to action in promoting multidisciplinary orthogeriatric care for the elderly. These toolkits are funded by UCB and Amgen. However, the scientific content was entirely independent, and the writing was influenced by the members of the Ffn. Okay, so this will help us in establishing orthogeriatric services, fracture liaison services, and the policy toolkit will help us support the policy making, which is the fourth pillar of the global call to action. So right now, there are 7 national Ffns in the Asia Pacific region. I think we have the most number of national Ffns, and there are new national Ffns which are being established, namely Ffn Pakistan and Ffn Hong Kong SAR. There's also Ffn Russia, which is now being established. So hopefully this webinar and this meeting will also encourage other countries to establish their own national Ffns. Okay, there's also the European FLS Academy and Network, in which I think this is a collaborative work between the IOF and the Ffn, in which we are supporting also the secondary fracture prevention program. So this is another venue for us in helping in post-fracture care treatment of patients with fragility fractures. This is very important. The Ffn has several special interest groups, namely the hip fracture audit special interest group, secondary fracture prevention, the vertebral fragility fracture interest group, the hip fracture recovery research group, physiotherapy, and perioperative care. These are the groups which are responsible for all the webinars, the meetings, the surveys that we have been circulating around through the Regionalization Committee. I'm sure each and every one of you, our multidisciplinary participants, you'll be able to find your interest in this special interest group. So visit the website and try to join the special interest groups of the Fragility Fracture Network, and you will really find much learnings in this special interest group. And again, we will be launching an orthogeriatric global survey. It's the goal of the Ffn to promote the promotion or the establishment of orthogeriatric centers throughout the whole world. So this is like similar to the Capture the Fracture program of the fracture liaison and the fracture liaison service of the IOF. So we will initiate this process at the Regionalization Committee workshop in the upcoming Global Congress. Again, another reason for us to attend the Global Congress. Also, for those of you who are not only interested in hip fractures, for the orthopedic spine surgeons, we would like to promote the vertebral fragility fracture special interest group. Okay, because we think that the focus should not only be on hip fractures. So if you are into this, we also invite you to join this special interest group. And of course, as Professor Passion has mentioned, all of our efforts are now geared towards supporting the WHO, the Decade of Healthy Aging. So we're having collaborations with the Global Coalition on Aging about WHO osteoporosis and healthy aging strategy. Our goal is in the next 10 years, we should be able to answer the question, what have we done to contribute to this call by the WHO? And I think the Ffn supports this WHO Decade of Healthy Aging. And because of this, we will also be having a UCB Japan sponsored symposium, which is supported by Ffn Japan in this coming year's pre-Congress regional meeting on the 28th of September. So I hope you will join this pre-Congress regional meeting, which is a part of the Global Congress. Okay. So at this point, I would like to introduce the chair and the co-chair of our next session, the Keynote Talks. Okay. The first is Dr. Joseph Lai. Is actually the Vice President of Ffn Philippines and also the President of the Philippine Orthopedic Trauma Society. And to join Professor Lai is Derek Chan, who is the Vice Superintendent of the National Taiwan University Hospital Hsinchu branch and also the Executive Director of that hospital. He's also an attending physician of the Department of Geriatrics and Gerontology and a clinical professor of internal medicine at the NTU Hospital in Taipei, Taiwan. He is very popular for establishing one of the models of FLS in Asia Pacific region, which is in Taiwan. And he's also the co-chair of the Asia Pacific Fragility Fracture Alliance. So Joseph and Derek, I'll pass the screen to you.
Thank you very much, Arwin, for the very nice introduction and pleasant day to everyone.
Good afternoon, everyone.
Yeah, I think we'll start off with some distinguished speakers, 4 of them. One is an orthopedic surgeon, others are geriatricians. They're all interested in varied research, mainly in orthogeriatrics. Okay? And since our topic is mainly on the acute hip fracture management, and later on we'll also talk about mapping pathways of care and also hip trauma registry. We'll start off with our first distinguished speaker, who is actually well known to all of us, orthopedic surgeon, because he's also an orthopedic surgeon like us. Professor Takeshi Sawaguchi works in the Department of Traumatology in Fukushima Medical University. He's the director of the Pelvic and Joint Reconstruction Unit, the Trauma and Reconstruction Center in Shinjuku Yurigaoka General Hospital. He subspecializes in hip and knee joint surgeries and also in trauma, specifically in pelvis, lower extremity trauma, and also certainly for fragility fractures. He's the past president of the Japanese Society for Fracture Repair, a past chair of the AO Trauma Japan. He's a current, he will be the chairman-elect of the AO Trauma Asia Pacific within the year, and a board member of the Ffn Japan. So let's all welcome Professor Sawaguchi, who will give us actually a case-based discussion on acute multidisciplinary co-management of a patient with hip fracture.
Hello, everybody, and thank you, Dr. Lai and Dr. Chen, for sharing my talk. And I'll talk about the case-based discussion about the multidisciplinary approach. I'll start this case. This is a 95-year-old male. He has comorbidity of hypertension, isomnia, moderate cognitive impairment, and aspiration pneumonia, and he has hospitalized with aspiration pneumonia twice within 1 year. And he had the history of gallbladder surgery, cataract surgery, and left hip fracture with ORIF 5 months ago. And his working status was walk with a walker, only indoor walking. He lives in nursing home for the elderly, and he has visual and hearing impairment, glasses in daily life, and height is 155 centimeters and body weight is 50 kilograms. And this is a X-ray. He had a hip fracture of the left side 5 months ago and was fixed with a nail. And right side is a comminuted trochanteric fracture, relatively long fracture, and this is a traction view. The classification of the fracture is AO31A22, and this is a 3D. You can see the fracture very well. And preoperative findings is he has several comorbidities, and he had medication of aspirin, glutathione, and amlodipine bacillate, and lansoprazole. And in the laboratory data, you can see that PO2 is 54.3 and elevated white blood cell, and he has some level of anemia and albumin level of 3.3, and he has some renal dysfunction, and also the slightly elevated CRP, and base blood sugar is 128. The preoperative planning is the orthogeriatric approach. You have to think your initial plan and what has to be done preoperatively, and what should be the goal of optimization, and what is the treatment goal for this patient. we have to think of all of this. Preoperatively, we had to have a fluid resuscitation and have to measure the fluid intake and output and adequate fluid management and also pain control. In the ER, immediate infusion and also for the pain control, we need to have a regional anesthesia, mostly the fascial iliac compartment block. Preoperative assessment was pulmonary assessment. We check the chest radiogram and also the CT and sputum culture. And this is the X-ray of his chest and also the CT. And you can find on the right-hand side, the lung CT, that there is some pneumonia, and this is aspiration pneumonia. And he was put on antibiotic therapy. For the preoperative planning, you have to plan the type of anesthesia with a general anesthesia or local anesthesia, spinal, epidural, or conduction anesthesia, or the nerve block. So this patient had aspirin medication 100 milligrams per day, and he was planned for the spinal anesthesia because aspirin does not have much influence on the breathing. This is a surgery on the day of admission, long nail and sacrilege wire, and he was put in a HCU post-operatively. This is a post-operative findings, day one. This is a frail patient, and respiratory condition was stable, and the laboratory data shows the anemia and some renal dysfunction. But he removed the IV tube himself. He was crying out loudly. As also geriatric approach, what is happening to the patient? What should be done to improve the situation of the patient? And what complication is likely to occur in this patient in the future? Who should be involved in the treatment? Let me interrupt at this point and discuss a little bit with the faculty or the participants, or ask the question.
Maybe we can ask the other speakers what they think about the plan post-operatively.
Yes.
How would you approach this patient who has just undergone a complicated surgery, and right now he has apparently crying out loud, thrashing? Would any of the speakers would like to share their insight?
He probably has some delirium.
May I speak? I'm Antony Johansen. I'm a geriatrician in the UK. So I've seen patients like this. I've looked after about 10,000 people with hip fracture over the last 25 years, and he's very typical. I think it's always very exciting to see patients presented from another country, because you think it's going to be very complicated and very different, but actually patients are the same the world around. And when I visited Japan, the ward round I did there, even though I couldn't speak the language, I recognized all the patients and the problems. So the main problem, the commonest complication of hip fracture surgery, and surgery of any sort in frail older people, is what this man has, which is delirium. And it's very important for us in orthopedics to remember that bleeding isn't a common complication, infection isn't a common complication, wound problems aren't a common complication. Orthopedic surgery is very good. Patients fall apart because they get delirium, and what he needs is very sophisticated management of his delirium, which is a talk which I could do for 2 hours. It's very, very complicated. But if you want a simple explanation of how to manage delirium, you cannot look for one problem and cure that problem. This isn't a urine infection. This isn't because he's got an aspiration pneumonia. This isn't because he's got bleeding. This isn't because he's hypoxic, because he's got acute kidney injury, or because he's in a strange place with lots of noises of the intensive care setting. It's not because he's in pain, it's not because he's on painkillers, it's because all of those things happen together, and you need to manage all of those things and deal with all of the detail. There is a brilliant paper by Mark Antonio in the Journal of the American Geriatric Society, which takes people like this and talks exactly about how they look after them to reduce the risk of delirium, which this man has, from 50% down to 25% of patients. It's a beautiful paper, not because it's a randomized controlled trial. It's a very good research paper, but it tells you exactly what to do. There is a list of things you need to do, and not only to look for the pain, but it tells you what to do about the pain. So I cannot recommend that too highly. I will put it into the chat.
Okay. So post-operative day one, this patient had restriction of the body. What do you think from the faculty? What do you think? Do you often do this or not? Because he was in the ICU. So the ICU people put the restriction of the body.
It's Jacqueline Close from Sydney.
Yes.
The use of physical and chemical restraint in the management of delirium is largely not evidence-based, and the reality is that restraints, either of a physical or chemical nature, cause more harm than they do good. They're likely to prolong the delirium. And as Anthony says, the strategies for managing people with a delirium need to be much more sophisticated than just restricting their movement. So on the whole, people avoid the use of restraint. It certainly was used in the past, but is not supported by the current evidence base. So it isn't something we would support.
Yes. Okay. So the question is, did we deal globally? What are the preventive measures of the delirium? And since the patient's general condition was stable, he was moved to HCU to the orthopedic ward. In the orthopedic ward, patient's body restraint was removed, and patient's family were asked to accompany him. However, because he was crying loudly at night, we used the haloperidol, and we judged that the pain control was inadequate, and added analgesics. On the fourth day after surgery, he became able to communicate. So the restraint was not ideal. It should be avoided, and we have several measures to help him to recover from delirium. So delirium, as Anthony said, there are several causes and several measures to prevent and avoid triggers and worsening factors, identify and treat possible causes, early volume and electrolyte repletion, and avoid hypoxia, provide sufficient pain therapy, review medication, look for inadequate drugs, adequate nutrition, and early surgery and provocative geriatric treatment, optimal early rehabilitation, and management of bowel and bladder function, and minimize use of physical restraint, early detection and treatment, post-operative complications, and environmental modifications and non-pharmacological sleep aids and cognitive stimulation, and manage disruptive behavior, and particularly agitation and combative behavior, monitoring high-risk patients with validated scores like a confusion assessment method. These all should be included with the post-operative or the perioperative management of the hip fracture patient. Any comments or some additional? This is very difficult to cover by orthopedic surgeons. That's why we need multidisciplinary approach, not just the psychiatrists, but also the nurses, the physiotherapists, and all other people.
Takeshi, it's Jacqueline Close again. It's worth saying that when you have people with disruptive behaviors, they are usually a symptom of something.
Yes.
And so it does take time to start thinking, is this hunger? Is this thirst? Is this urinary retention? Is this constipation? Is it pain? Is he just in a strange environment? Where are his family, etc.? So it does take time. And I think that's why geriatricians are on the wards. They have more time on the wards, whereas surgeons are often busy in the operating theatre. So that's why you need teams to look after these people, to try and understand what are the triggers for the behavior, learn to look for the triggers and do something about them before behaviors start to escalate.
Yes, and
yes, Antony Johansen again. I agree. The issue is that the patient doesn't seem to make sense to us, but the patient makes sense to themselves, that there is a reason for what they're doing. They may still be living in a period 60 years ago in their memory, but there will be a sense and a story behind all of this. And the more you can understand why they're behaving like that, why they're shouting that, as opposed to something else, the better. And the treatment is usually the family. The family is hugely powerful and cheap and non-toxic, usually, as an intervention to get into hospital to help. So somebody who understands them and understands why they're frightened of this or that is terribly important.
And the problem, for instance, in Japan is we don't have enough geriatricians to help us in the ward. Fortunately, we have one, but most of the hospitals, they don't have the geriatrician at all. So, but we should understand this and share this knowledge between our teams and at least try to improve the delirium of the patient. That's the present situation in our country. But I think it may be very similar in other Asian countries.
Takeshi, it's Matt from the UK.
Yes.
I'd just like to say I'm an orthopedic surgeon like yourself, and I rely on my colleagues like Jackie and Antony, who are experts in this area. But I think it's brilliant that you're talking about this as an orthopedic surgeon, because with the best will in the world, as you pointed out, there's not enough geriatricians in the world to look after all the patients. So it's up to orthopedic surgeons and our colleagues in nursing and therapies to be able to recognise the symptoms of delirium and at least ameliorate the obvious factors that contribute into that delirium. So although it's wonderful to have people like Antony and Jackie, who are true experts, world-leading experts in this area, to guide us, we all need to be aware of these problems, and that's why it's so important for someone like yourself to be talking about this, because it's not just a geriatrics problem, it's an orthopedic problem, it's a nursing problem, it's a therapy problem. Congratulations on bringing this to the forefront as an orthopedic surgeon. I know it's not easy as an orthopedic surgeon talking about these issues.
Yeah. Thank you very much. Yeah.
Takeshi, it's Robin Spearin from Australia.
Yes.
I'm wondering about this optimal early rehabilitation. So within your country, who does that? Do you have allied health professionals to do that, or is that left to the nursing staff?
The rehabilitation is we usually let the patient out of bed on the next day by a physiotherapist.
Right. Okay. And would a physiotherapist be a common staff member across the Asia areas?
At least our country, you have enough numbers of physiotherapists. So the power of the physiotherapist, we have enough.
Thank you.
Yeah, Anthony, please.
I was just going to say again, the challenge for this patient is that is a really nasty fracture, and that is going to be very, very painful. And if you give him enough painkiller to get him out of bed, he will be very, very heavily opiated. It'll be extremely difficult to get him up early. The whole purpose of surgery is to be able to get him up to try and avoid him getting an aspiration pneumonia. But somebody with such a nasty fracture, this is very challenging. It's like the situation for patients with pelvic fractures. Often you can't deal with the pain adequately to cope, and there may have to be a period of rest while he recovers from the immediate bleeding hematoma pain before he can get up. A very challenging patient, this one.
Yeah, that's why we operate this patient on the first day and try to have a good reduction. Now, what else is important measured in the post-operative phase? Is there any pain management algorithms at your hospital? I think most of you have. And the pain management is the adequate pain management help the mobilization facilitated and lower delirium rate and shorten the length of hospital stay. So early onset of sufficient pain treatment reduced delirium by 35% from some reports. So the pain management, as Anthony already said, is very important. This is some pain management algorithm. We depend on the strength of the pain, but basically we use acetaminophen and sometimes the opioid and not non-steroidal anti-inflammatory medication. But sometimes, especially before surgery, we can have the block to reduce the pain of the patient, or after the infusion of some painkiller to reduce the pain of the patient. That helps to reduce the delirium and also helps the post-operative rehabilitation. And this patient, post-operative phase, and on the first day, the moving was difficult and impossible, but the second day start to let him to sit, not staring at the ceiling, and third day he could start to walk. Any comments?
My comment, analgesia will be very difficult. We have got poor evidence on nerve blocks, and for somebody who's taking his drip out, it will be difficult to think about putting an infusion in or something like that. To fill him up with enough painkiller to allow him to get up will be very difficult. But one of the strongest painkillers that I know is to explain to the patient why the pain is there, to warn him. When you see his x-rays that he came in with, you can't tell him we're going to take your pain away by doing an operation. You're going to change his pain, so it's not bone-on-bone pain, but he's going to have a lot of pain after surgery. And if he knows that that's going to be there, and particularly if his family is there to explain it to him again and again and again, why it hurts, then I think you can try and titrate his painkillers with their help. But I think doing this without his understanding is very, very difficult.
That's important.
Takeshi, could I comment on the
Yes.
use of non-steroidals in older people? So on the whole, geriatricians don't like non-steroidals, but I think we've probably gone too far. I do think non-steroidals do have a role in as part of multimodal pain management. We are very worried about GI bleeding and knocking off somebody's renal function with non-steroidals, and we'd be very cautious in people with heart failure. But we're quite happy to hand out opiate-containing analgesic agents, which also have side effects. So there is some evidence to support the use of non-steroidals. There was a study looking at intravenous paracoxib perioperatively in terms of reducing delirium post-operatively. So I don't know that a blanket no to all non-steroidals is appropriate. I think there are some individuals who do benefit from it, and it means you can probably use less opiate. You just have to be cautious.
We like to think about using non-steroidals. We don't want you to use non-steroidals. You have to have a full understanding of the patient's kidney function and gut and everything else before you're allowed to prescribe. So Jackie can prescribe, but you can't.
I see. So let's proceed. And the post-operative phase, the speech therapist, we usually do this swallowing function evaluation and starting. It depends on the patient, but starting of the swallowing rehabilitation. And this is post-op, 6 weeks and 5 months. He recovered to pre-injury function level walking with the walker. And he was also put on osteoporosis medication. Post-operative phase, general recommendations are regular geriatric rounds was need to be adapted to the elderly and co-development of other set and nursing care plans and prevention of complications, UTI, pressure scores, chest infection, and embolism, etc.
So your regular orthogeriatric rounds will be difficult if you don't have a geriatrician.
Yes.
I've put the Mark Antonio paper into the chat so everybody can see it, but it essentially contains a checklist of things that I do when I see a patient, and there's no reason why your juniors shouldn't be doing that. That's what I hope my juniors are doing this morning on the patients I'm not seeing. There are 10 areas and 30 things that can be done, and going through a checklist like that and building a checklist into the post-operative ward round for the junior doctors and the nurses and the therapists. But to create a checklist like that may be your best way of providing orthogeriatric support without having geriatricians there to do it. Because delirium is overwhelmingly the most important thing you're trying to deal with. There are very few other things outside that checklist that need to be looked at for post-operative care.
Thank you. And after the, not after, during the in-hospital time, we have the educational course for the lecture for the family and the patient. We explain what is osteoporosis and fall prevention and meal for osteoporosis and osteoporosis medication. We have this class once a week. And after discharge by a liaison manager, we continue osteoporosis treatment. After discharge, it's a fracture liaison service. Our fracture liaison service, 1 year after this service, the medication rate is about 70%. It's a little bit low, but it's improving. And the take-home message from my talk is also geriatric co-management approach can be better address the problems. Comprehensive patient evaluation, including a geriatric assessment, have an improved patient outcome. And delirium is a frequent complication of elderly fracture patient, and its outcome will be improved by a systematic proactive approach. And good control of post-operative pain reduces delirium and improves the patient's ability to participate in rehabilitations. And effective pain management is to repeat the assessment and secondary fracture prevention by fracture liaison service. Finally, I recommend the participants the recommendation of the book and apps. There are 2 books from the Ffn. Also, Geriatrics is the 2nd edition, and also Fragility Fracture Nursing. It's a free book you can download from the Ffn homepage. And the other one is AO Trauma Free Geriatric Apps regarding the delirium or post-operative management or the pain management. This can be easily, you can find in this free app. Thank you for your attention.
Thank you very much, Professor Sawaguchi. Derek, we'll proceed to the next speaker.
Sure, thanks. And we are kind of running late, so I'll have an introduction very short for Professor Matthew Costa. But he's very famous. Probably I don't need to introduce him at all. So he is the professor of orthopedic surgery at Oxford University, and he's also the past chair of Ffn and also the current chair of Ffn UK. And today he's going to give us the talk on the importance of mapping pathways of care and obtaining quality data. So to you, Professor Costa.
Thanks, Derek, and thank you, Joseph, and thank you to Iwan and Louis for inviting me today. It's a great pleasure to speak to you. So I'll speak sort of reasonably quickly, so I know we've got a lot to get through today. And just to say what a fantastic case presentation from Takeshi there, which highlights many of the issues we're dealing with, which really brings out the importance of multidisciplinary care, which is probably the single most important message today. But what I'm actually going to talk to you about specifically is about data. And this is quite a dry subject, so I won't concentrate on exactly how we collect data, what sort of database we use, and how we code things and how we analyze it. I'm going to just talk about the importance of data quality, particularly from a patient perspective. So some of you are very much aware of this. Some of you have been involved in a project called the World Hip Trauma Evaluation, which has been running for over 10 years now, and this is increasingly involving centres around the world in looking at data following hip fracture. But the data I'm going to present today is from the UK. It's from the early phases of this particular study. Anyone who'd like to find out more, either get in touch with me or the website for the study, the World Hip Trauma Evaluation, is available on the Oxford web pages if you just Google it. So before we started collecting data on patients, we really wanted to work out what data was most important to collect, because there's so much data out there. Your hospitals and your primary care units and your pharmacies all contain so much data, it's almost impossible to think about that. And bringing that data together in a meaningful way for patients is incredibly difficult. So we decided not to try and do that ourselves. We decided to go back and ask the patient which of these data sets were most important to them, how we could collect meaningful data from a patient perspective. And we needed to be able to measure these data or collect these data, and particularly outcome data that we were very interested in the context of not just one hospital or one unit, but across a whole country, a national level data set, so a registry, if you like. And this was very much alongside the National Hip Fracture Database in the UK, which is the UK Hip Fracture Registry, which I know Antony's going to talk to you more about after my talk. So the way we went about this was to ask the patients themselves what they thought about their experience of hip fracture, including patients with dementia or cognitive impairment, either from themselves if we could, or from their carers if not. And we explored the patient's whole experience of the hip fracture from their first moments after their fall and injury through their transfer into hospital, how they got there and what happened to them, and then their treatment surgically and post-operatively on the wards, and then into their rehabilitation at home, out to the hospital or whatever residential institution they went to, out to a year after their injury. And what we discovered there were two quite distinct groups of patients. There were those patients who were very active before their fall, and that was a small minority of patients, but the great majority were frailer, very much along the lines of the patient that Takeshi described in the case presentation previously. And the expectations of the patients after their injury is very much linked to their pre-injury status. So the patients who had a very high level of function beforehand, often the younger patients with low comorbidity and certainly less frail, had an expectation of returning to their pre-injury level of function, as most of us would do after a traumatic injury, after a fracture. But actually the majority of the patients in this hip fracture group have no expectation at all of getting back to their pre-injury state. In fact, many of the patients, even a few weeks after their injury, couldn't separate the effects of their hip fracture from their aging trajectory. So the hip fracture was subsumed into their acceptance of getting older and not being able to do the things they were able to do in the past. And that was really fascinating to me to work out that this wasn't actually their expectation to get back to their pre-injury level of function. They actually accepted this injury as part of their aging trajectory. And so our expectations on their behalf of recovery need to be tempered by that fact. So what they did tell us were there were some themes in common, some domains of health they thought were important. And some of them are obvious, like mobility. After a hip fracture, you'd expect that to be high on the list of patients' priorities, daily activities of living and so on, and self-care. What featured very highly was actually anxiety, and very specifically a fear of falling. So I'd often thought as an orthopedic surgeon that my patient wasn't walking out of their home after their injury because I hadn't fixed their hip fracture well enough. But it turned out that many of those patients didn't go outside the home because they were so frightened of falling over again and injuring their other hip or injuring another part of their body. Interestingly, pain, although it was on the list, was actually much further down than we expected. Patients accepted quite a large amount of pain, not the acute pain of the hip fracture that Anthony was talking about, but the longer term pain that patients suffer after this sort of complicated, severe injury. They accepted that, and it wasn't the top of their priority list. And although death was on the list of priorities, it certainly wasn't at the top. So we've now got an idea of what sort of things patients think are important. And the next conundrum was, how can we collect data to actually record the things that patients think are important? So I won't go into this in detail, but we basically did a large cohort of patients with hip fracture and followed them up over a year very carefully, and collected a whole series of outcome measurement tools to try and look at which data we could collect and which was most practical to collect. And then we went back to the patients and asked them what they thought about these data sets. We actually showed the patients the data and said, which are the most practical, which do you think are the most important, which are the most relevant to you in your recovery after hip fracture? So what was the result of all this, and why am I talking to you about this today? Well, we really came to three conclusions. The first was that high quality data can be collected in large cohorts of patients in national level patient data. So it can be done, not just baseline data from hospitals, but also follow-up data as well. It is possible to do it. There's a lot of my colleagues said it wasn't possible to follow this patient group up properly to collect these sort of data, but it is. But what we discovered, and no surprise to most of you on this call, will be that the data set has to be contained. It has to be very simple. It needs to be the minimum amount of data you need to collect, not everything you'd like to collect, but the smallest amount of data that you think is important to the patients. And that's where the concept of a minimum common data set comes in. And again, Anthony and Chris are going to talk to you a little bit more about this later. And high quality data does need resource. It's not cheap to collect high quality data. It does need to be properly resourced. But even more important resource, whether it's financial or in terms of technical support and so on, is the clinical input. Because if you don't have the clinical input, by which I mean multidisciplinary clinicians involved in the care of these patients, then you often end up collecting the wrong data at the wrong time point. So the patient's opinion was that we do need data to collect, or we do need to collect data to improve patient outcome. And that actually the data that we collect needs to be based on the patient experience. This was a very strong message from the patients. And actually, interestingly, general health related quality of life was actually considered to be the most relevant outcome for patients following a hip fracture. Not a hip score, not a capability score, not a daily activities of living score, but actually general health related quality of life was the most important outcome from the patient perspective. So this is fine, but how can we use these data to improve patient care? We've shown that we can collect it, it's possible, but how does this matter? How can we use the data to help patients? So just to give you a quick update on the World Hip Trauma Evaluation, this is the UK data set. There's now 26,000 patients in the data set, and this is from 40 of the larger hip centres in the UK. And that data is representative of the whole population of patients in the UK with hip fracture. And we collect these data as an adjunct to the minimum data set that Anthony and Chris will talk about later. And it's really an add-on to the National Hip Fracture Database. It's based around our registry and how that data is collected using the same systems and time points and so on. So some of you would have seen this graph before, but it's still one of my favorites. And this is really powerful data of how we use data after the event. So on the vertical axis here is health-related quality of life, and some of you will be very familiar with this scale. It actually goes from about -0.5 up to 1, and it's anchored at 0 being a health state equivalent to being dead, and 1 being perfect health. So it gives you an idea of what we're looking at here. And on the horizontal axis, here's the time. It's the first year after the patient's hip fracture. So before their injury, the average patient was actually only had a health-related quality of life of around 0.56, so only just above half of maximum perfect health, which just reflects the fact that these patients are frail patients before they have their hip fracture. It's not that they're high functioning beforehand, they weren't. For most of them, actually they had significant problems, significant reduction in quality of life even before their injury. Immediately after their injury, they actually have a health-related quality of life worse than being dead. You might think, well, that makes no sense. Well, how can you have a health-related quality of life worse than being dead? But if you're in the worst pain you've ever had and you can't move and you can't look after yourself and you're incredibly frightened, if that was a permanent state of health, how many of us would want to carry on living like that? So in that context, immediately after a hip fracture, I think many of us would think if this was permanent, we'd be better off dead. Of course, after the initial treatment, patients recover, and up to 3 months, the recovery is very rapid, up to around half of their previous health-related quality of life. And there's a little bit of improvement out to 4 months. but not that much actually between 30 days and 4 months on average. And actually between 4 months and 1 year, there's an age-related deterioration in quality of life rather than continued improvement. So why were these data important? Well, for two reasons. Firstly, this was the first time in the UK, and this has been replicated, indeed other people did it before us, in other countries showing very similar graphs. And it shows that your window of opportunity to intervene to improve your patient's outcome, to change the recovery trajectory is quite small. You've got to act early and act hard to actually make a difference to these patients. But perhaps even more importantly than that, for us in the UK at least, we were able to show that patients after a hip fracture had a permanent health-related quality of life reduction of around 20%. So they lost a fifth of their pre-existing quality of life after this injury. And to put that into context, that's the equivalent of having a small stroke or having a diagnosis of multiple sclerosis or Parkinson's disease. So what we did was actually use this data to inform our political masters, the policymakers in our country, that hip fracture was a massive problem to patients. 70,000 patients every year in the UK having a hip fracture, and their quality of life was affected in the same way as having a stroke. But the amount of resource put into hip fracture care, particularly multidisciplinary care, was a fraction of that put into stroke. And in particular, the amount of research money that was put into hip fracture was tiny, almost non-existent. And you think of all the money that goes into research into Parkinson's disease and multiple sclerosis, and how little goes into hip fracture. So we've turned that round now, and we've managed to persuade our government, our policymakers, to fund a lot of research in this area. And these are just a few of the trials that we've done based around the World Hip Trauma Evaluation Cohort. These are randomized controlled trials. Some of them will be familiar with you. So White-4 was a fixation trial. It was comparing two types of fixation device, and White-5 with two types of arthroplasty. But perhaps more importantly, and I totally agree with Antony about the importance of the perioperative care, we're looking at White-8 was a study about reducing infection. White-9 was about managing patients' blood afterwards, anemia. And probably the most exciting study that we've just started is something called LIT, the White-10 study, which is actually about reducing delirium in these patients, about intraoperative interventions that can reduce delirium. And we've actually just started the 11th trial within the series. And all of these trials are large multi-centre randomised trials costing, well, actually many millions of pounds. But the government put this money in because we were able to demonstrate using data that there was a massive problem here that we needed to address to improve care for patients. So I think for the interest of time, I'll probably stop there if that's okay, Joseph and Derek. And I'll move on and let Antony speak, because I'm conscious that we're running a little bit behind time. So if there's time later, we could perhaps come back to how else we can use data to improve patient outcomes. But I think for the purposes of getting through today's session, probably best if I stop there. Thank you.
Thank you, Professor Costa. So then we are going to move on to the next session. So if anyone has questions, please put it in the Q&A part, and then we will answer at the end. So Joseph?
Yeah, our next speaker is actually we already heard from him earlier, giving his comments to Dr. Takeshi's talk. He's the first UK consultant appointed as a full-time ortho-geriatrician. Professor Antony Johansen works in the trauma unit of the University Hospital of Wales in the School of Medicine in Cardiff, and he has co-authored actually the British Orthopaedic Association's Blue Book on fragility fracture, and also helped in the formulation of the NICE guidelines on hip fractures. To give a talk on hip fracture registry and the minimum common data set, how can we involve everybody? Let's all welcome Professor Antony Johansen.
Thank you. It's a great honor to be here, and I'm very pleased to have been invited to speak to you. I can't make my slides move on. There we go. The joy of working in Europe is that hip fracture is not a big problem. It is a huge problem, but it's nothing like as big a problem as you facing in the Asia Pacific. The question of how far and how big the numbers are going to be over the years ahead is a really scary issue. And so much of the world's hip fracture is going to happen in your region, so it's a great honor to be here. I need to try and get you to enthuse about writing down numbers and collecting information. And when I started as a registrar going into an orthopedic ward, a geriatrician going into an orthopedic ward 25 years ago, looking at hip fracture patients, the first thing that I did was to start writing down what I was doing. And there was a standardized audit of hip fracture in Europe, data sets that had been described, built largely on the Scandinavian hip fracture registry's approach. And that gave me a guidance as to what I ought to be recording about my patients if I wanted to understand what was happening for them. Back in those days, I didn't even have a laptop back then. And this was all done on paper. But by collecting information, I suddenly went from being the geriatrician visiting the orthopedic ward to being the only person in the hospital who knew how many hip fractures there were, who understood what the age distribution was, what their length of stay was, and what the implications of that was for their care. And this was a very important piece of work that I did. I said to the orthopedic surgeons, I will take over the care of all the patients who come in on a Thursday, and I'll shorten their length of stay. And because I was collecting basic registry data, this is probably white zero as a study, I was able to show that I could reduce their length of stay, and wrote a business case for an orthogeriatrician consultant on the back of that. So using standardized audit data to try and drive change in care as the way that things always worked. And I eventually got a laptop and got Excel and started drawing graphs of what was happening to try and challenge the delay to theatre that the unit had many, many years ago. And that's a laborious process. It's really tedious to collect all this information and to do all of that. But happily in the UK, we've evolved the National Hip Fracture Database. That's our national clinical audit of hip fracture. And it functions as a registry. And if you go to our website, www.nhfd.co.uk, you can see all of the information. You can see everything that I now run the NHFD. You can see all of the information and download nearly all of the data that I have access to. It's a very open access process. And the first thing I got to do was to start drawing the graphs for me so that I didn't have to do this. So I can look for my hospital, I can type my hospital's name in here, or you could type somebody else's hospital's name in here, and you can see what's going on in terms of performance in that hospital. You can look at how we're affecting time to theatre, for instance. It's much more sophisticated than that. We've been monitoring mortality for some years, knowing whether my mortality in my hospital is normal, is above average, or is significantly a problem is something that's challenging to disentangle. But we've again found systems to case mix adjust information so that mortality is visible to hospitals in real time on the website. And not only visible to hospitals, but visible to senior health service managers, to local politicians, local journalists as well. So we're very open with this and allowing data, therefore, to drive change. But we're flexible at the same time. So there was this pandemic last year that arrived, and immediately we changed the data set that we were collecting. We built in what I'd call a custom field, asking hospitals to record the COVID status of the patients who present to them. And that meant that during the course of 2020, we were able to very rapidly monitor the impact of COVID on outcome after hip fracture, not only for the whole of the country, but giving that information back to individual hospitals. So you can look here at the shape of the pandemic within my hospital and the huge impact of post-operative coronavirus infections during both waves of the COVID pandemic. So we're turning over information in a very rapid form, but we're also making the information very freely available. And that's demonstrated by this editorial in the Bone and Joint Journal from this spring, which we turned around in a couple of weeks when we were asked to write it. And the exciting thing about it is that we've described everything that happened in the UK in terms of COVID in 2020 in a report that came out in the spring of 2021, very, very quickly. But the most impressive thing about it is that any one of you could have accessed all the same data as I used to write this editorial. So any one of you who wished could have written the same editorial, all the information freely available for you and anybody else to look at. And there's a lot of information that you can start looking at. If you've got a structured system for monitoring what goes on in your hospital, you can look at performance and how that changes. So we can look at all aspects of anaesthetic care, of surgical care and so on. And you can monitor how that changes in my hospital following the publication of the health trial, following the onset of the COVID pandemic. Changes in how patients are looked after are monitored in real time. The challenge, of course, is to compare your hospital with somebody useful. And the most useful hospital for me to compare my hospital with is obviously how it was last year. So to see what the trend of performance changes in my hospital over time in response to individual changes. But it would also be nice to be able to compare my hospital with other hospitals. So these are the other hospitals in South Wales. who I could look to see whether my hospital's performance is better or worse, and to question why it's worse than some of them. But if you want to be sophisticated about things, you need to be very clear about what aspects of care you should be making comparisons about, and comparing a hospital in one place with very different services, very different structures somewhere else can be quite confusing and distort the picture. And what we've tried to do is develop key performance indicators. And these aren't about how well I looked after the patient or what we did to the patient or that sort of thing. What they're about is the patient experience. So how soon does the patient see a geriatrician? How soon do they have surgery? How soon do they get out of hospital? Do they get an appropriate operation? Those key performance indicators have been designed to allow me to compare what goes on in my hospital with the other 170 hospitals in the UK. That gives us a very much more powerful way of challenging our local health managers to say, we need to improve. All of these hospitals are doing much better than us. Why can't we? Why can't we deliver what they're already delivering? We know these hospitals. Even more challenging, though, is to compare my hospital with hospitals in other countries, or indeed my country with hospitals in other countries. And when we wrote this paper a few years ago, there were 7 national registries around the world. There are now significantly more than that, but can I compare what's going on in my hospital and how my patients in my country are performing with other registries around the world? Well, we tried that using the data from the registries for a single year. And it is possible to draw comparisons, but there is a risk that individual hospitals or individual countries have different approaches, and you can see that the age captured by different registries is different in different countries, which will pose a challenge to that. But even so, it's possible to look at what's being reported by these different registries and notice really interesting things, like the fact that there seem to be far more extracapsular fractures in Australia than there are in Europe. So comparisons between countries might draw out really powerful messages that would be worth investigating. But that only works if you can make direct comparisons, and it proved very difficult. And we could only in the paper report where there was reasonably comparable data from the different countries. But the registries in Norway and Denmark are very much more registry. That they weren't really collecting information about the patients they were looking after, assessment data. And in the absence of that, it's quite difficult to make formal comparisons of what goes on there and how the different surgical practice there might compare to the surgical practice in the UK. So to try and pull all of that together, one needs to have a shared attitude to the sort of data that is collected, and to ensure that we're all collecting high quality data, but asking the same questions of our patients. And Chris, who's on the panel today, and others have written this chapter in this open access free book, which you can easily access and have a look at, taking you through the questions of fragility fracture audit. So there's lots of reference for you. But this is the Ffn's minimum common data set, and the workshop that we'll have in our next session is really working through some of the detail of this and questioning whether this is still the most appropriate way for you and us to be building the minimum data set that you would use in the design of your local registry. The information you should be collecting. Do you need to collect anything more than this? This looks like a questionnaire that you could just adopt in your hospital, in your country, but it's not a question. This isn't, it looks like a tick box page, but this isn't necessarily a questionnaire that somebody needs to go through and tick boxes. For many of these questions, I suspect that your hospital information systems will be able to populate these. What this is about is the definition of the questions and the categories and the fields that should be collected, and that will be the focus of our next session. Thank you.
Thank you very much, Professor Antony. Again, we will be entertaining your questions after the session. So I think we have the final speaker for the session to be introduced by Derek.
Okay, so the last speaker is Professor Jacqueline Close. She is the professor and consultant geriatrician at the University of New South Wales. And then she did a lot on the hip fracture registry. And then she's the co-chair of Australian and New Zealand hip registry working group. And she's also working for both Ffn Scientific Committee and also co-chair of the Asia Pacific Fragility Fracture Alliance Hip Fracture Registry. So that's why she's going to give us a talk about the Hip Fracture Registry Toolbox. Let's welcome Professor Close.
Thank you, Derek and Joseph, Arno, and many thanks for organising this meeting. You do a great job for hip fracture in the Asia Pacific region. In the interest of time, I'll go through this pretty quickly, and the reality is I'm really just signposting this resource that's available to people. So it's the Hip Fracture Registry Toolbox. It's been launched about a month or so ago, and it's a collaboration between the Asia Pacific Fragility Fracture Alliance and the Ffn Global. This is the document on the left that we're talking about. You can go to the Asia Pacific Fragility Fracture Alliance website and download it. It's in two formats. You can download the interactive PDF, and I'll show you some features of the interactive PDF, or you can just have a straightforward PDF to read. So why hip fracture registries? And you've already got a flavour from the previous speakers. So the burden imposed by hip fractures is already substantial in the Asia Pacific region, but it is also set to grow exponentially over the next 30 years. And hip fracture registries now have been demonstrated to be a very effective mechanism of benchmarking how we perform in hip fracture care, particularly when you've got clinical care standards to be able to compare with. And if you are working at a hospital level and doing some quality improvement type activity, the registry, if you have access to real-time data, is a very good way of being able to evaluate the impact of any quality improvement activity. And as Anthony says, to start with, there was only about 8 hip fracture registries when that paper was produced. There are now 18 hip fracture registries that we're aware of across the globe. Now, the registry doesn't exist in isolation. It needs to be supported first and foremost by the evidence. So the clinical guideline, it might be a national guideline, it might be an international guideline, but the guideline basically is a synthesis of the evidence. And at the end of the guideline, there is a set of recommendations that say, this is what best practice looks like. Some countries will have clinical care standards, which will have distilled out some of the key recommendations and put them into a clinical care standard. The standard with a small set of recommendations is nothing unless it has measurable quality indicators. And then, of course, if you have measurable quality indicators, you need to be able to report those indices. And that's what the hip fracture registry is. It is a vehicle for being able to report in hopefully a user-friendly format how we perform against those quality indicators. There's quite a lot of evidence now from across the world saying that actually clinical quality registries are a cost-effective way of driving up quality of care. So, and at a relatively low cost. So, for example, this is just work from the Australian Commission on Safety and Quality in Healthcare. They looked at a number of registries in Australia, and as an example, for our national joint registry, for every $1 invested in that registry, there is a return of $7. So it is incredibly cost effective in terms of driving up quality care. A lot of people, when you start talking to them about setting up a hip fracture registry, start to feel very uneasy and start to worry about the resources required to be able to do that. And that's a very reasonable consideration. So the NHFD actually have given that some thought and put some dollars or pounds to the actual costs required. So when the NHFD was very first set up, it comprised 7 members. So there was a clinical lead for geriatric medicine. That's now Anthony. There's an orthopedic lead, 3 project coordinators, and there were 2 people looking at IT. Now, when you consider that team supported 200 clinical teams. So at that stage, it was 60,000 hip fractures in the UK per year. That's now around 70,000. So the cost at a central level, we are talking about £5 per case, or US dollars, $6.70. You also have to then think about consider the cost of who's collecting data at a local level. And in the UK, it's often a trained nurse. And overall, it's estimated that the collection of the data is probably about an hour's worth of work. So that was estimated to be £32 per case, or in US dollars, 42, almost $3. But if you look at that and you compare it to the overall cost of treating hip fractures, the cost, both combined of central and local costs of that audit, we're talking about 0.5% of the cost of hip fractures. It's a tiny fraction of the overall cost. So in terms of the toolbox that we have launched, there's a lot of stuff in it. Here's an example of the epidemiological data. So this is specifically the Asia Pacific area. So we've got things on incidence, number of hip fractures, mortality. There's a huge variation in mortality following hip fracture across the Asia Pacific, which requires more thought as to why that should exist. And all of those, of course, links to the references. This is one of the most important parts of the document. This shows you where the clinical guidelines already exist across the world. So in the Asia Pacific area, it'll be Australia, New Zealand, Japan, and South Korea. But there are links to all the guidelines. So anybody starting out or thinking about setting up a hip fracture registry or at an early stage, there are guidelines already out there. There are already clinical standards. There are already quality indicators and links to all those sites. So it's very much about trying to share learnings over many years and trying to help people starting registries in other countries. It takes you through the practical aspects of setting up a registry, the importance of having strong clinical leadership and engagement, but also the importance of having buy-in from a wide range of stakeholders. Anthony talked about how he built the case for change in Wales. It's very much about building that case for change, thinking through how do you get initial money to set up your registry, but actually how do you then ensure and secure longer term funding. Talks about the importance of just piloting the registry, starting small. If it's overwhelming to collect all the data to start with a small amount of data. Governance structures are incredibly important, and ethics will vary remarkably across different countries. So it is important to have robust governance structures in place. We're going to be talking much more about the minimum common data set later. So needless to say, we support the Ffns minimum common data set as the obvious place to start. But you can also visit our YouTube channel to hear a little bit more about the experiences of many people across the world who have already been on this journey for a number of years. So Paul Mitchell interviewed a number of us who have gone down this route over the years. So if you are not excited about reading a PDF, here's your opportunity to click on the website and listen to some of the experiences that have been shared by people who have been on that journey. There's a whole suite of appendices that are shared from across the world. So multidisciplinary care, what do we mean by multidisciplinary care? The stories about how registries have evolved over time, what sort of things went on right at the very beginning, setting up steering groups, what sort of things, what topics were covered, and it gives you some ideas about some of the facility level audits that we've also undertaken over the years. So again, these are resources that are there to be shared and to try and avoid people starting from scratch and reinventing wheels. So there's the website again, free to download it, and we hope that it will become a useful resource. It was designed originally for the Asia Pacific region because it was funded by the Asia Pacific Fragility Fracture Alliance. But with the collaboration with Ffn, we are hoping to be able to translate the toolbox into a number of different languages and alter the epidemiological section of it so that it is fit for purpose in a number of regions across the world, particularly in South America, where we're also seeing an exponential rise in hip fracture. Lots of acknowledgements for the work that has been undertaken in terms of developing this resource, and a particular thanks to Paul Mitchell, who has been instrumental in driving this forward. I know Paul is hopefully online, but there's a storm in New Zealand, so he says his internet at the moment is extremely ropey. But a number of societies also involved in this. So that's just a very brief introduction and signpost to go and have a look at the toolkit, listen to some of the YouTube videos to get a feel for what it's been like setting up a registry. So anybody thinking of or at the very early stages of setting up a registry, please do utilize the resource and the experience of those that have gone before you. And there are many of us who would be more than happy to be contacted as well for anyone wanting any advice. Thanks very much.
So thank you. So before we move to the next session, maybe we can have one or two quick questions. I know there is a question by Shelley in the Q&A part. The question is, the risk of fall post-surgery is greater among those with post-op delirium. In one hospital in Philippines requiring a 24-hour caregiver to reduce is probably an answer, not a really question. Anyone has some question to ask?
Yeah, I think the question is for the other speakers, if they're also using, let's say, paid caregivers to help out patients who may be in delirium so that we can facilitate their post-op rehabilitation. Is there like a system that you hire a caregiver for that particular problem?
That's a very difficult thing to do. Most hospitals, certainly in Australia, won't fund additional support on a one-to-one basis. Most wards are asked to special within their nursing ratios, which is extremely challenging for nurses who are extremely busy looking after other orthopedic patients on the ward. The family are the key to it all. So involving a family, we shouldn't see family as visitors. They are not visitors, they are integral to the care that is provided to somebody with a hip fracture who is delirious. And I can tell you for us currently in Sydney, where we have a further outbreak and we're in lockdown again, we are excluding families from wards, and it makes providing care for people delirious extremely challenging at the moment. But on the whole, most hospitals won't agree to fund additional one-to-one nursing. The reality is the priority is to prevent the delirium in the first place, spend time getting to know the patient if they do become delirious, but you can try and interact with them in a more meaningful way. But one-to-ones is not the way that we are supported to provide care.
How about in UK, Anthony?
Very, very similar in terms of the funding question, and our experience of patients' families being excluded has been the same again. It's very difficult if you're, as Takeshi's patient, if you don't understand where you are and what's going on, and if your quality of life has just descended below that of death, it's very difficult to see why you would want to try and get better. And you want to get better. Patients tell us they want to get better to get home to their family, to get home to their previous existence. So unless the family is there to draw them towards that and to remind them what that is, they're not going to be successful. And they will explain that this person is going to fall because she's trying to go to the toilet, not because she's demented and difficult, but because she's constipated and you haven't sorted that out, because she wants to go to pass water, because she always gets up every hour to pass water at home. They will understand her in a way that we don't. And the whole interaction of family with patient is irreplaceable by staff with other priorities on their time. And I think it's very important, if we're looking at the way that services are developing, that the best geriatrician for the patient is their wife, is their husband, is their daughter. It's not me. And we may construct a health service where it's all done and it's all very technical, and you measure how many pieces of metal you put in, and we measure how many wood rounds we do. But the registry shouldn't be measuring our experience. It should be measuring patient's experience, and the patient experience is all about the family and home.
Well said, sir. And we actually agree with that, because even in the Philippines, our patients are, especially the elderly, have a very close-knit family. So even all the way down to the grandchildren, actually can be in the hospital just to take care of them. And we even require family members to be swabbed for the COVID test, just to be able to be with the patient during their admission.
Yes, and in the UK, we've broken down the extended family. It's just not the same thing as it used to be generations ago. And we've had to replace it with geriatricians, but you're in a position to not get rid of the family as an integral part of patient care, and to use them and do.
Are there any other questions for our four panelists?
I'm Jae-young Lim. May I have a question from South Korea?
Okay, go ahead.
I think the main problem to establish the hip fracture registry in many countries, the funding source is the main issue. So I think that it could be supported as a type of the the pilot project from the government, but I'm not sure how can we get the government to continue to support the fund to the hip fracture registry in the country. So I wonder how to develop this system in UK and other countries.
So maybe Professor Costa or Professor Johansen?
Well, I think just from my perspective, and Jackie mentioned this, that the hip fracture registry toolkit that Jackie talked about, Jae Young, is brilliant because it's full of all kinds of practical examples of how all of the hip fracture registries use data to try and inform politicians to change policy, essentially provide money, because fundamentally it's cheaper to treat hip fracture patients well than it is to treat them badly. So if they have complications, if they have delirium, they have longer hospital stays, they use more resource than if you get them well and get them back to their family early. But the toolkit that Paul produced and the policy toolkit previously on the Ffn website, which is freely available, has so many good, useful bits of information about how to try and influence policymakers and liberate resources.
Yeah, so that Jackie's presented the kit and the economic argument, but it's very difficult to convince people to invest in something that isn't there. We haven't got one of these. Give us loads of money and we'll set one up. The way to do it is to just get on and set one up. So I was doing it in my hospital. There was no funding. It wasn't very expensive. It doesn't take a lot of time and effort, particularly if what you're collecting is information you need to know anyhow when you're seeing your patient. So get that information and then start drawing graphs. And I remember a lecture in Cardiff 20 years ago where I stuck the graphs up and the Welsh finance minister said, "We're terribly pleased with this audit structure that we're funding." And I pointed out that they weren't funding it. And 10 minutes later, they were funding it. That was just one hospital's data being shown as a demonstration of what could be achieved and the potential savings that could be achieved, as Jackie's demonstrated. A proof of concept, extending it to other bits of the country is much easier than saying, oh, you've got to fund the whole country in one single step.
I think if you wait for a pot of money to arrive on your doorstep, you will never get started. I think it's good to start small. It's also interesting when you start asking around, a lot of people are already collecting their own data. They've got their own little audit systems going on within countries. So it's only a matter of pulling one or two people in, developing and agreeing a minimum common data set, which we're going to come on to. And just even if you only just start counting how many hip fractures, and then you have to be smart in terms of working out your local context, and every country will be different as to how you argue the case for change. Colin Curry once coined the phrase, if you think data is expensive, try ignorance. And that's spot on. So, high quality care costs less, and there is more and more evidence emerging now that registries are one mechanism for improving quality of care. It's not the only mechanism, but it is a very solid mechanism for driving up high quality care.
Just one other slight pointer, Derek. I mean, it's so as I mentioned in my talk, then all of the money that's been invested, certainly in the UK and increasingly around the world, in research into improving outcomes for hip fracture patients, none of that was happening 10 or 15 years ago. And the reason was because the funding bodies didn't recognise hip fracture as a big problem. So until we have the data that Jackie's talking about from the registries to show how big a problem this was for patients, and suddenly the funders said, wow, this is massive, we had no idea, here's lots of money. So yeah, I can't emphasize enough what Jackie and Anthony said, collect the data now, and then the data will bring you in more resources once people see the data and can realize how important it is for the patients.
Yes, if you're only collecting data in one hospital in your country, that is your national registry, and the other hospitals will want to join. Don't try and do it another way.
Hey, okay. Derek, can I just make a quick comment? It's Paul here.
Sure.
Yeah, just reflecting on all of these national hip fracture registries that have come into existence. Actually, it usually starts with two people, where two people decide to say, do you know what, this will be a really good thing in our country. So for the UK, it was Dave Marsh, an orthopaedic surgeon, and Finbar Martin, a geriatrician, and Jackie will blush, but in Australia, it was Jackie, a geriatrician, and her colleague Ian Harris, an orthopaedic surgeon. And it goes on country by country by country. There were literally about 2 people who said, we could really do with one of these things. This would be really, really great. And then they built an alliance and brought in all of the other colleagues and all of the societies and everything else. But it actually starts with 2 people. And we did the math that there's about 200 countries in the world. And currently, as Jackie said in her talk, 18 have some kind of national hip fracture registry at very different stages of development and participation right now, but that means 182 don't. So if 2 people in 182 countries said, let's do this, that's 364 human beings, could be the nucleus of the army of enthusiasts to make this a really big thing. So, you know, got to start with a couple of people.
All right, this is probably the most encouraging ending because we need to move on to the next one. So I'll go back to Aaron for the next part.
Thank you, Derek and Joseph, and to our speakers, keynote speakers. At this point, we will have to move on to the next part of the meeting, which is actually the minimum common data set consensus workshop. But before we hit on the real workshop, we just ask 5 countries from the Asia Pacific region to tell their experiences about their national registry. So this is just a very quick presentation of 5 minutes each from each country. So the first to present is Professor Noriaki Yamamoto. He's a member of Ffn Japan. He's a board member. He's the director of the Niigata Bone Science Institute and Niigata Rehabilitation Hospital, president of the Niigata Bone Health Association.
Okay.
Yes, Professor.
Thank you, Chairman. Okay. Recently, we have 200,000 hip fracture in Japan annually, and we're still increasing another 30 years. Okay, this is the medical cost of aged over 75 years old for hospitalization in Niigata Prefecture in my town. Surprisingly, fracture is ranked the top of the medical costs among other major diseases. Fracture Network Japan started in 2012. In 2015, Ffn Japan was formally certificated non-profit organization. In 2017, Ffn Japan launched the National Hip Fracture Database in only 7 hospitals and now increasing 20 hospitals in the end of the 2020. We developed Japanese hip fracture audit from minimum common data set from Ffn Global Special Interest Group. Our characteristic is we make the 120 days and 1 year follow-up status of the patient. Here we have the 3 years report, and this slide shows the age of patient. Hip fracture patient is getting older. 2020, 30% patients were aged over 90 years old, so it's difficult to treat this fracture patient. This slide shows the physician or geriatrician involvement for the patient before surgery. We have few geriatricians in Japan, so mainly the general physician supported hip fracture care. According to the Ffn Global, the definition of early operation is as within 36 hours from the admission, improving the 2019, but most of the hospital worsened in 2020 because of COVID-19. Post-operative first day mobilization is still low in this study. Before fracture and after fracture, totally 65% of the patients received osteoporosis medication for secondary prevention. Last year, we Japan Ffn advocated best practice 5 criteria for assessment the care quality. First is seen by geriatrician or physician before operation. Second is received surgery within 36 hours. Third is post-operative first day mobilization. Fourth is osteoporosis medication for secondary fracture prevention. And 5 is 5 follow-up until 120 days. A rank means 80% achievement. If all 5 criteria get A rank, the hospital received gold. Okay, I showed this 2020 data. It's here the surgery is in the 36 hours. None of the hospitals achieved 80% in the early surgery. 2020 became the bad year for the hip fracture surgery because of the COVID-19. Most of the hospitals the delay of the surgery. Also, no hospital achieved 80% in the criteria 2 seen by the physician or geriatrician. Criteria 3 of the first day mobilization, 2 hospitals get A rank. concerning to the osteoporosis medication, 6 hospitals get A rank. Follow-up is difficult work, but 5 hospitals get A rank. Future work is a progress, so we need the improvement of quality of data. We try to reduce the missing data. Also completed the follow-up data of 120 days and 1 year. We want to widespread the project of all of Japan, so the feedback and the publication is important. Now we have the plan to HIP festival among participating the hospitals. In order to change the policy, we need the government notification and supporting and funding. So we are provoked public and political awareness. Also, we collaborate the new clinical guideline for the hip fracture care in this year. This is a summary. The registry is a clinical indicator in each hospital. So feedback system improves the quality of clinical practice. Also, registry is a widely spreads the best practice concept and the multidisciplinary approach. It creates a new community among the hospital and the medical staff. The destination is a policy change. The fracture care is in the political change is our essential goal. Okay, sorry. That's all. Thank you for the attention.
Thank you, Nariaki, for that wonderful presentation. I guess what's striking is that you have, the registry supports a feedback mechanism to support a quality giving of management for patients with fragility fractures. So we will reserve all questions and opinions later. So next to present is from Ffn Korea. He's an associate professor of rehabilitation medicine of the Seoul National University Bundang Hospital, and he's a board member of Ffn Korea, Professor Jaewon Byung.
Okay, thank you for your invitation and introduction. It's a great honor to be here. And let me briefly present registry establishing experience of Korean Ffn. Now we Korean might be in the 6th step to establish your registry according to the Ffn Toolbox and this infographic. But I assume that we still need to adopt common data set. Now let me introduce 2 kinds of nationwide registries in Korea. The first one is hip fracture cohort led by Yongchan-ha. That is mainly focused on osteoporosis management and secondary fracture prevention. Second one is FIRM, FORM database about physical functional recovery and rehabilitation. Those 2 registries were funded by Korean National Health Clinical Research. First, the hip fracture registry is a web-based database and includes electronic case report form instead of conventional paper-based data collection. About 3,500 cases has been enrolled in the registry. As a physical status assessment, ASA classification and cohort grade were used. The ratio of each grade is shown here. We compared our data to the national audits of 8 other countries. Baseline characteristics are not as different, but the rate of cognitive impairment and severe physical dysfunction is relatively lower than that of other countries. Besides, early operation rate is relatively low, and in-hospital mortality is somewhat lower than other countries. Professor Ha and orthopedic surgeon team published a study comparing the results of internal fixation to that of hemiarthroplasty based on Korean hip fracture registry. A second Korean registry is FIRM database led by Jae-young Lim and Yongchan Ha, which is about physical functional recovery and rehabilitation that I previously introduced. As you see, it has many items and scales that take a lot of effort to collect them. Clinical characteristics such as fall history, comorbidities, post-operative complication, leg power, muscle mass, and bone density were investigated. As physical functional scales, mobility and balance function, walking speed, ADL and cognitive function, frailty and quality of life questionnaire, and hand grip strength were assessed and measured. Professor Lim and rehabilitation team published a study about influence of comorbidities on functional outcomes based on this FARM retrospective cohort. 2 weeks ago, Korean multidisciplinary team published clinical practice guideline for post-operative rehabilitation in hip fractures. As a guideline committee members and co-authors, geriatrician, rehab nurse, nutritionist, physical and occupational therapists, as well as orthopedic surgeons, physiatrists, have actively participated with enthusiasm. I'll be very pleased if this guideline is helpful for your clinical practice. And I reviewed the Ffn registry toolbox, and I'm looking forward to participating and discussing this minimum and extended common data set workshop, because Korean registry is somewhat complicated and has many items. Thank you so much for your attention.
Thank you, Jaewon. It's very interesting to know that you have two versions of the registry. So yeah, this workshop will be very helpful for you. So listening from registries coming from high-income countries, we now go to experiences from countries with emerging economies. So the next to present, I think, is from Sri Lanka, Ffn Sri Lanka. I'm not sure if Sarat is here, but I think it's Dr. Telina Abiguna Sekura, who will present on behalf of Sarat Likamwasam, regarding the registry from Ffn Sri Lanka.
Yeah, thank you so much for allowing us to present our current situation in Sri Lanka. Our general aim is to enhance the care given for patients with fragility fracture in Sri Lanka. Aiming that, can you please stop? We are conducting the research in past few years, and then we identify these are the most recent publications from those our research in our engaging our fragility fracture network team. From those research findings, we identified there are substantial delays in admission to hospital and the providing the surgical management and the initiation of the rehabilitation program. Also, the less number of patients getting deep venous thrombosis prophylaxis, but incidence of this venous thromboembolism is rare. Then nearly half of patients are managed non-surgically, and also the non-involvement of these physicians in the care plan. We identified these as the main gaps according to our current finding. Regarding the remedial actions, it was affected as in all the other countries due to this COVID-19 pandemic. Then we have the discussions with relevant professional organization, even with during this pandemic session. Then inclusion of Ortho Geriatric module in the current Sri Lankan geriatric training process. It was started very recently with the help of the Sri Lankan government. Also, make the relevant authority, that means Sri Lanka government, Ministry of Health, the aware of the care gaps in our fragility fracture management. And then also we are planning and we are starting the expanding our research on the findings related to the maintaining this fragility fracture hip fracture registry, and with the members of the fragility fracture network of Sri Lanka, members in that particular team. Then feasibility of including other fragility fractures types into this registry, and the estimation of the burden of all types of fragility fracture in the country. We have separate studies, and we are now already started these studies. And also we are expanding our research areas to the other areas like sarcopenia and frailty in hip fracture outcome. Also the assessing the caregivers burden. So these are the current areas we are involving in Sri Lanka to develop this our fragility fracture or the hip fracture care to the Sri Lankan hip fracture patients. While working on these things, these research findings and developing our further improvement in our network, we identified this as a challenge. The current pandemic situation, as also some other speakers already mentioned, we have identified several financial problems. We are lack of this funding to initiate our work and going through with this work because we have to cover all countries. So we are planning to expand to all other areas in Sri Lanka. Currently, we are mainly involving in the southern region of the Sri Lanka. So this is the current situation of Sri Lanka. Thank you so much for giving this opportunity to present the current situation of Sri Lanka in this forum. Thank you.
Thank you, Telina. It's nice to know that the formation of registries is not only possible for those with high-income economies, even for countries with the emerging economy, it's still possible. And actually, that inspired us to also at least have a bold attempt to establish a registry. So going to that, I'd like to introduce from Ffn Philippines. He's actually the Assistant Secretary of Ffn Philippines, and he's a Clinical Associate Professor from the University of the Philippines, Department of Orthopedics, Philippine General Hospital, Gio Delgado.
Hello everyone, a pleasant day to all and sending you warm greetings from Manila, Philippines. It is an honor to be part of this panel. In behalf of the local organizers, we'd like to thank you all for tuning in. I'm part of a local team that has just concluded our local multi-center study on hip fracture management during this pandemic. We are currently still in the process of finishing our manuscript, but we would gladly share with you our experience, highlighting the significant role of the Ffn international community. Our journey began in 2017 when the Department of Orthopedics in our National University Hospital, the UP Philippine General Hospital, began conducting in-hospital symposia about orthogeriatrics and the multidisciplinary approach to treating elderly hip fractures. Moving forward, we were able to establish the first orthogeriatrics FLS in our country. Unfortunately, the pandemic happened and our hospital was converted into the primary COVID-19 referral center here in Manila. Because of the realignment of resources and manpower, our facility had limited capacity to accept fragility fracture cases. Patients were continued to be seen in other institutions who were still unfamiliar with orthogeriatrics and the FLS. It was during this time that our FLS core group at the Philippine General Hospital started a multi-center research project about orthogeriatrics and FLS. This project not only aimed to collect data during the time of the pandemic, but more importantly to introduce and promote orthogeriatrics and secondary fracture prevention competencies in the 12 hospitals that participated. Needless to say, the Ffn Philippines team continuously provided guidance. We likewise received unending support from the UP PGH Department of Orthopedics and collaboration coming from the UP Manila Orthogeriatric FLS Multidisciplinary Team, the Philippine Orthopedic Association, the OSPFI, the UP NIH Institute of Aging, and the UP NIH Astro Group, and of course, the DOST. More importantly, I cannot overstate how instrumental our international Ffn community was for our study. We were able to use the Ffn Clinical Toolkit and the Ffn Minimum Common Dataset, both of which were readily accessible. More importantly, we used the REDCap data collection system, which was a very useful recommendation by the Ffn President-elect Hannah Seymour. We likewise had valuable inputs from the ANZ Hip Fracture Registry Project Manager, Elizabeth Armstrong, when we had to present the proposal to our Department of Science and Technology. With the uncertainties amidst the pandemic, we still continued to push for our advocacy for the Orthogeriatrics FLS program in the Philippines. Hopefully, both applications for continued funding and our proposal to institutionalize orthogeriatrics and FLS as pathways of care will be approved. In addition, because of what we have learned during our project, we now have a better understanding of the local national processes and the different agencies and networks that can be tapped. We are optimistic that in the setting of continued researches, the possible creation of a future hip fracture registry is in sight. Thank you and mabuhay to all.
Thank you, Gio. Thank you, Gio, for experience regarding establishment of the registry, and hopefully our 2-year approved project will continue to be. So next, would love to hear from what we say the benchmark of hip registries in the Asia Pacific region. May we call on the Communications Committee Chair of the Ffn, who is also an adjunct associate professor of the University of Notre Dame School of Medicine, well known to all of us, and he's a board member and a steering committee member, Pacific Fragility Fracture.
Hey guys, it's lovely to hear you. It's I'm Paul here, and what a stimulating meeting. Lovely to see lots of friends across Asia Pacific and old friends from the UK, Antony and Matt and everyone else. I'm going to speak for uncannily about 30 seconds, and just to say, what are the key messages from Ffn New Zealand? As I said before, Jackie and Ian in Australia, and indeed their counterparts, Mark Wright, who's an orthopaedic surgeon in Auckland, and Roger Harris, led the charge to make the Australia and New Zealand Hip Fracture Registry a really cemented part of our healthcare system, which has now been alive for 5 years. If there's one key message that comes from our experiences, who pays for hip fractures in your country? And that might sound like a stupid question, because in most countries it's the Ministry of Health, or maybe it's the people who are the individuals who sustain hip fractures. But really understand who pays for the majority of the hip fractures. For us in New Zealand, we have this odd organisation called the Accident Compensation Corporation, which is a so-called crown entity, part of the Commonwealth thing, that is a government organisation responsible for injury prevention. They pay for hip fractures. And so Osteoporosis New Zealand, which I had the good fortune to chair for several years, we engaged with government and said, look, you guys are paying for this stuff. Maybe you want it to be measured, benchmarked, and optimal care be delivered. And they did, and they have, and they've paid for this for the last 5 years. So in all of your countries, figure out who pays for hip fractures. And it might be a multitude of organizations. It might be the Ministry of Health. It might be some big insurance companies, but figure out who it is and then speak to them with one unified voice as a national group of professional organizations conduited through Ffns, I hope, to say that better hip fracture care is cheaper hip fracture care, as Jackie said earlier. If you want to learn anything about the ANZ Hip Fracture Registry, go to www.anzhfr.org, and there are loads of beautiful reports and things there that could inspire you as to what national hip fracture registries could look like. And Jackie's already done a wonderful illustration of this hip fracture registry toolbox thing that we've compiled. And please have a look at that, because we have tried to distill all of the brain trust of everyone who's put their heart and soul into establishing a hip fracture registry across the planet into a document and a bunch of YouTubes that we will grow and expand, and we hope you guys will participate in the future to say, how do you build one of these things? When you get a Jackie and an Ian, a Finbar and a Dave, how do you make these things real? So Irwin, uncharacteristically, I'll shut up quickly. That's all I've got to say. Thanks.
I'll ask help from Jackie in moderating the actual MCD. But before we start the MCD consensus workshop, I introduce those who will really manage the minimum common data set, a consensus coming from the hip fracture registry special interest group. We've already introduced Matt and Antony earlier. And I would also like to welcome one person who really worked on streamlining the minimum common data set. She is very instrumental in establishing the Spanish National Hip Fracture Registry, and she is a consultant physician at the Hospital Universitario 12 de Octubre. She's Professor Cristina Ojeda Thais. So Cristina and Antony.
Okay, so I've shown you this, and I can't recommend it too highly. What we're going to talk about today is some of the areas where the minimum common data set might need to be adapted, or the way in which it was written in the countries in which it was designed may not suit the health services in other countries. And though I'd love us all to be collecting exactly the same information so we could do nice big academic comparisons of all the different countries around the world, that's of course not the point of a national registry. The point of a national registry is for you to be sure that it captures what's going on in your country accurately enough. It's all very well if you can measure things that matter to me in my country, but that's no use if you're going to try and convince your local politicians, your local fundings, that what you're measuring is meaningful. And you also have the real challenge when you're collecting information that shows that people in one hospital seem to be performing very well and in another are performing very poorly, that the people who are performing poorly will always blame the data. So we have to design systems that are as simple as possible, that involve collecting as little information, but we have to avoid it being ambiguous, and uncertainties over that can be really challenging. So that there's enormous amount of work that we should each do on this, but it would be a great shame if all of the national audits evolve to be slightly different from each other, then even more different from each other. And we can't get a sense across the world of what's happening. And we can't then learn from each other about what's happening. So this is a very small number of questions to ask about hip fracture, and as has been said a couple of times so far. If nothing else, if you just count how many fractures you have in your hospital, you are already ahead of the game in terms of knowledge. I found that enormously powerful. Once you know how many hip fractures happen, you can use the literature, you can use simple information from your hospital to work out how many beds are occupied and what the cost is of hip fracture. and that becomes a really powerful lever. So the minimum common data set is how many hip fractures have I got? But we'd like to know a bit more than that, and to learn from it, we need to ask these further questions. I don't want to just go through what is a very well-defined and well-structured question set here, because you can all read this and you've all been sent this in advance of this meeting, and we'd like you to go through it at the end of this meeting and feed back to us. But what Christina's done in the course of the last few months is to take the existing minimum common data sets questions and to set it up against the 10 national registries who've reported up until now, and look to see what those national registries are collecting in terms of the possible questions that might be asked. And that involved her with great tenacity going through hundreds of possible questions that were asked by one audit or another, but not by all of them. And what she has shown very nicely is that the questions that are contained within the existing minimum common data set are largely being collected by the audits. So 7 out of the 10 audits are collecting an audit number and that sort of thing. So there is still a very high level of consistency in using the minimum common data set across the national audits. And what we wondered was whether the minimum common data set that's been around for a number of years is still fit for purpose, whether it's too small, whether we ought to be collecting additional information, or indeed whether it's too big, whether it's in some ways intimidating and looks too challenging for people trying to set up a new audit structure. So what we've questioned is whether, if we are creating a new version or updating the version of the minimum common data set, what questions should be in it? Questions that you can't run an audit without collecting. And then are there other questions that could be viewed as optional if they're relevant in your country? But it would be nice if those questions have the same structure for all the countries who might adopt them, so that international comparisons would be possible. And then there are custom fields. So Matt has talked about EQ5D as a custom field that he's using so much in the UK to drive all sorts of change and research. Those are questions that it would be nice for people to select a previously used system, but you don't need to have those. And we all do invent questions that are very typical of our own local health economy that we need to know, that don't need to be part of the minimum data set, so that the work that you do in your country will be a combination of this minimum set, some of the options that the Ffn have defined, and then things you can define for yourself or borrow from elsewhere. And running through the questionnaire, the question set that we've seen, there are some particular areas, and there are 9 particular areas that I was going to open for people to comment on, where things are perhaps worth adapting in the existing data set. 4 of the national registries that Chris looked at, recording the date and time of the trauma that causes the hip fracture. The other 6 don't. I was challenged on a ward round yesterday as to why there was no way of telling how long it took for the ambulance, several hours for the ambulance to pick somebody up. And on the next patient, this person spent 17 hours on the floor before she was found with her hip fracture. So I can see, and when we first ran the audit in the UK, we used to collect the date and time of the fracture. But we've stopped doing that as in general, people don't spend very long coming into hospital. But I recognize that around the world, that's not the nature of hip fracture care. That in some countries, many patients won't ever come to hospital, and we struggle to get them anywhere near into a registry. And in many countries, the patient may spend hours, weeks, or days at home before they're able to get to a hospital for care, or while they're raising the money to pay for their care during their time in hospital. So we think that adding in at least an optional extra question about the date and time of trauma would seem to be a logical development of the minimum common data set, or the extension of the minimum common data set. The date and time patients arrive in hospital seems to be an important question, It seems an obvious question to ask, but when you're thinking about how you use the minimum common data set, you need to bear in mind that may not be the same as the hospital to which people first present. And if people are attending one hospital and then being transferred to an operating hospital, they may have a very prolonged period somewhere else. So thinking about how you capture that and understand that is particularly important. And the difference between arriving in hospital and presenting to an orthopedic team is probably worth distinguishing as well. Because if we're trying to look at the quality of the care delivered by the orthopedic team and the multidisciplinary team within which we all work, the time that people arrive in the operating hospital may not be quite the right thing to be measuring, because 5% of my patients fall over in the operating hospital and break their hip in the operating hospital. So actually, it's not the time they arrived in the hospital several weeks ago, it's the time they first present to the orthopedic team that may be the point at which the clock should be starting. So we need to think to work on how we define the arrival time. And then the other time point that's there and worth thinking about is the time that people actually get to an orthopedic or an orthogeriatric ward. In the UK, we have time limits for how long people are meant to spend in the casualty department in the emergency unit. And those targets tend to drive patients out of the emergency unit into a ward somewhere, but that may not be the right ward for them. If people are being moved to the wrong ward, actually measuring when they arrive in the correct ward, in an orthopedic ward, in a ward where people understand them and their fracture and their perioperative care and their delirium and so on. That may be, again, a point at which the clock should be measuring. So we may need to think about developing those three questions and the definitions underpinning them for the Ffn minimum common data set. And you need to think in your own countries, are all of our hospitals using the same approach to these definitions? Owen, I could stop there for these 3 points and let people contribute before I go on to the next three.
Anthony, thanks very much. Okay, so I'm going to give some of the Ffns a chance to respond to some of those suggestions. And it's important to remember that when the minimum common data set was originally constructed, it's a small number of countries that were really part of it. We talk about the UK being the largest hip fracture registry in the world. They have 70,000 hip fractures a year. The reality is in China, we're talking about over 400,000 hip fractures a year. In India, 320-something thousand hip fractures a year. That is the reality of our future. So these indicators are probably more relevant and important indicators for countries with less well-developed services. So how long you wait to get to the hospital is really important for some places. I think Sri Lanka was a good example of that. So comments, feel free to put your hands up. I need to make sure I can see everybody, or post the questions. Paul, you've got a question.
Yeah, thanks, Jackie. Great presentation, Anthony. Do you think we should be working with international quality and safety and healthcare bodies? I was just having a dig online whilst you were talking, Anthony, and I come across the International Society for Quality in Healthcare. Now, Jackie has worked extensively with the Australian Commission on Safety and Quality in Healthcare. We've done the same thing here. You guys have done the same thing in the UK. Other people have done the same in their countries. Could we try to argue at a global level with international safety and quality bodies that actually high volume, high cost, as Colin used to say, there could be some pretty universal standards that would be desirable to be achieved across all of the world's 200 countries? Is that something we should do?
If we can define those, yes. I think that's the sort of thing that could come out of the number of registries that we have at the moment, to actually have not so many quality standards as we individually have based on things, but the basic minimum that a patient should be able to expect. If we can define those, and a couple of things perhaps, but surgery you know, the timing of, well, the time to surgery is not really the issue. The time to getting out of bed after an operation is a measure that we ought perhaps to be trying to expect as a basic human right. If you present with a hip fracture, somebody should do something to get you out of bed, and to actually have an Ffn statement of a single expectation as a human right might actually gain some traction with that sort of international organization.
So can I make a comment here? Yeah. I think, Paul, it's a very good idea, because there are organizations which accreditate hospitals against the quality standards, like, for example, JCIA. And if there is a standard on, you know, the hip fractures or fractures and related to the outcome assessment, then I think it's going to be very useful. And automatically, those organizations or those hospitals which are accredited with these organizations will have to follow the standard, and that will expedite the implementation, and you know, individuals will not have to work. It's basically from the safety organizations or the accreditation body that it will be coming to. So I really like this idea. Thank you.
It's an interesting point, Paul. But I guess I kind of feel we're in charge of our own. This is our opportunity to take control of our own destiny. We have multiple countries here online. The same will happen in other parts of the world. If we as people who are heavily invested in wanting to improve hip fracture care can say, actually, across the globe, this is what we think should be happening. We can engage with international quality and safety organizations, but we've got a real opportunity to do it ourselves, and we should be pushing it. And the Asia Pacific region is a really important region. It is a huge region in terms of what we're faced with in the future.
I agree absolutely, and this will be my last comment because many other friends have more important things to say. But you know, it comes down to 3 bullet points, doesn't it? When you try to get things across to government and big organisations like that, could we distill, as the beginning of your point, Jackie, 3 bullet points, speaking to Antony's comment and Aisha's comment, something about time to surgery, something about early mobilization, about something about post-operative care, out of the, you know, 7, 12 quality clinical standards that we have in the UK, here, there, everywhere, that we could actually try, as Antony said, it's like a fundamental human rights charter for hip fracture patients, that we push as an international quality standard for care, that this is the beginning. And, you know, you can grow from 3 to 5 to 6 to 12. What do you think?
Yeah, so in the UK, we don't get people out of bed for 3 days after presenting with a hip fracture. That half of that time's waiting for their operation, the other half is waiting to get sorted out afterwards. That point that somebody's sitting by their bed after presenting with a hip fracture is a very nice time point that rolls in so much of care. Challenging that as a focus for a human right would be interesting.
Comments from other parts of the Asia Pacific region? What's feasible? What do you think are the most important things that we should be focusing on?
Jackie, I think there's a question from Sibtain Ahmed from Pakistan. I think he asked, are there any customizable data management softwares for establishing registries that can be linked to the hospital's electronic health records? So I think that's very important. It's quite a challenge for many hospitals in the low to middle income countries, regarding softwares. Is that necessary to start a registry? Is that really needed, the software?
That's a tricky one to answer. Lots of, and I can't speak for most of the Asia Pacific, of course, lots of hospitals all operate on different software packages and platforms. The whole idea of the registry is to be able to easily benchmark against other hospitals. Certainly in Australia, we have a number of hospitals who try to extract their data straight into the registry from their existing electronic medical record system. And it is possible to do. You can customize it into an Excel spreadsheet and upload it into the registry. That's not a huge resource implication. However, I am not an IT guru, but somebody like Stuart Fleming could provide some advice on that, and Stuart is certainly interested in supporting hip fracture registry starting up in the Asia Pacific region.
Okay, may I do just a small comment? Of course, it is interesting to be able to automatically export the electronic health records and the variables that we are interested in. But I think with all of the suffering that we clinicians have had with electronic health records, that has still, it's still a thing that needs to be improved. And I think it shouldn't be a limiting factor in at least establishing your own local registry. I mean, at least the Spanish hip fracture registry and several other audits have just started with a normal Excel spreadsheet that is submitted to a data manager. The data manager just imports that to their own data set, and that works. So if you think in a small scale, you start with that first step, you start with the measuring culture, then you present the numbers to your own local board of directors or IT team, and they're going to want to help you. But I think that's easier to do it that way than to do it the other way. If you try to make a perfect registry from the start out, I think it's going to be a lot harder.
Yes, I think that's very true. And let me rephrase it. So if we can have, some templates, like one with a minimum clinical data set, the other one with a different outcome, what is needed. So I think that will facilitate, facilitate individuals to convince people who are actually taking care of such patients. Like, for example, we have, as I see in this group, there are mostly initiatives have been taken by orthopedic surgeons, geriatricians, etc. But we have, people, orthopedics, are not very keen to initiate take initiatives, such initiatives, though they themselves want, but because of their other commitments. So if there are, some clear-cut guidelines, easy to start with, and coming from reputable registered organizations known for this work. So I think this will help the Asia Pacific countries, because the organization of the healthcare system is totally different from what you people are experiencing. Like, for example, NHS is a totally different ballgame as compared to the countries like ours, where hospitals, they are providing mostly services, and the government is not at par to the international standards. So I think the challenges are totally different, but again, to have to expedite the process, because this will, I think, help if we have the templates for like minimum clinical data sets, or with different outcomes, extended one maybe.
It's worth pointing out. So Matt has typed into the chat session maybe the importance of countries and context, that actually standards need to be relevant for for that particular country. So you heard information from from Sri Lanka this evening, where only not even 50% of patients actually get surgery for hip fracture. So we're busy setting standards for 36 hours or 48 hours or whatever. Actually, for the people of Sri Lanka who break their hip, the goal might be actually to get surgery rather than worry about 36 hours or 48 hours. So there has to be a context to all of this. But what the minimum common data set allows us to do is actually collect that information in a consistent manner. And what Antony is actually suggesting here is some new indicators that are not routinely collected by a lot of us, because the idea that you don't come to hospital and don't have surgery is an anathema to some of us, but it's not to many other parts of the world. If we can agree the minimum common data set, the standards might need to be context specific, particularly if you need the standards to get your resources to be able to fund your registry as well.
And using the minimum common data set to question the rates of non-operative management is really powerful. So in the UK, during COVID, we had to write to hospitals and challenge them for not operating on patients because we could see they'd given up. When I started, 10% of patients didn't have surgery for hip fracture. They were viewed as not fit by surgeons who didn't really understand why they looked so poorly. An anaesthetist who'd come from an elective ward. And much of the impact of orthogeriatric work in the UK has been in changing the definition of not fit for surgery, which is pretty much nobody now in the UK. But in other countries, the reason isn't fitness. It's the design of the health service, the funding of the health service, etc., etc. One of the hospitals in the UK with the best outcomes has very high non-operative management rates. They've got very good outcomes. Non-operative care is not necessarily the wrong thing for some people, and some health economies it may not be the wrong thing. But if we all have the minimum common data set and collect it, we can actually start looking at the outcomes of non-operative management in different health economies, and that would be a really powerful piece of work to do.
There's a comment in the chat, what will be sufficient post-operative follow-up for a registry? So again, I think it's different
we'll come on to
across
that.
country. You're going to come on to that. Well, I'm
Yep.
aware of time, so Anthony, I'll let you carry on. You and Chris carry on.
Okay, so the other 3 points that I was going to raise before we come on to follow-up question is cognitive status. I think we all recognize, and Takashi's patient demonstrates the importance of starting to look at people's cognitive status. Recognizing people are demented before they come in or have memory problems before they come in is a really good way of anticipating who's going to get delirious. And it's a really powerful indicator of future. The minimum common data set talks about the abbreviated mental test score, which is great if it exists in your country, your language, and if it's a meaningful construct, but it probably isn't. So we need to think of another way of defining what we mean by cognitive status. Is the patient known to be demented? Are they screened as having cognitive impairment on whatever's the most appropriate screening tool for your country? So we need to tidy up the definition within the minimum common data set on that. Nutritional risk, an impressive number of the national registries have recognized the vital nature of nutrition and have built that in. And again, a categorization to encourage people to be recording whether people are malnourished on presentation. The implications of nutrition for outcome are huge, but we need to find a way that encourages people to be recording that routinely, because the best evidence on improving hip fracture outcome is all to do with getting the family in to feed the patient. Food is hugely important, so we need to refine that part of the definition. And the questions of bone protection. When the minimum common data set was defined, we were really just looking to see whether people were on any form of bone protection. But I think the modern age of osteoporosis medications, tracking what people come in on and what people go home on is a very attractive idea. In the UK, we record the drugs that people were admitted on and the drugs they were sent home on. That's probably too complicated for the minimum common data set, but I think we should define something for the optional structure, a system that everybody can use, so that we can really understand this. Because every person who comes in not on treatment half of people who come in not on treatment have previously had a fragility fracture and are a missed opportunity that we should be flagging to government. So there's some additional work to do on the minimum common data set in terms of further assessments. And then just to finish running through the loose ends for the minimum common data set, question of measuring length of stay. We all think we know what we mean by length of stay, but I suspect most of us on this in this workshop will have a slightly different definition. Is it length of stay in your acute orthopedic ward? Is it in your acute hospital? Is it in your hospital system? Is it in your hospital system and any community hospitals? Is it in your hospital system and a care home that somebody goes to for routine rehabilitation, a rehab facility? We need to be quite careful that we're all recording exactly what that means, because we will all have different definitions of what we mean by a care home and what can be provided in a care home. So if we're going to make comparisons about length of stay between countries, and lots of people have done that sort of trial, and that's of course where the cost of hip fracture is so hugely wrapped up in length of stay, we need to have a very clear glossary of what we mean by a care home in my country might be a hospital in yours, or vice versa. The question of follow-up is really poorly agreed on by the national registries. So only 2 of the 10 registries were doing follow-up at 120 days. And I think Matt has beautifully demonstrated with his graph that 120 days is the point at which people have recovered, and after which it's not recovery, it's aging that takes over. So as a single time point, I think it's quite clear that 120 days is the logical time to be measuring. That's much more challenging than measuring outcomes at 30 days when the patients are much more accessible and much more recent. But 120-day follow-up, I think we need to work on. And then the question of what you build into follow-up at 120 days is really challenging. The minimum common data set asks about reoperation, but that's a really challenging thing to question, and you're asking an awful lot of questions about reoperations, whereas reoperations are a really rare outcome. And what should we be measuring at 120 days? Is it where the patient is? Are they alive? Some form of mobility? But trying to think intelligently about that definition of outcome at 120 days is something that we need to do in refining the minimum common data set. I'll stop there.
Right, thanks very much, Anthony. Chris, did you want to add anything? I know you have done a huge amount of work in terms of pulling this all together.
No, Anthony has summarized the key points pretty well. I think this is actually an opportunity to make the minimum common data set less European-centric, which I admit is one of the disadvantages it has, and allow it to be tailored more easily for international comparison. And in that sense, we probably would have to agree on the minimum common data set and then the extended version, and definitely on the variable definitions on what we recommend to be measuring and the continuity. For example, what is discharge? What is nursing care? What is the type of ambulation, functional dependence, etc.
People feel free to ask questions. Tanawat from Thailand has asked about the challenges of following up at 3, 6, and 12 months. It is enormously challenging. It's whether you get additional information that is of value by collecting at multiple time points. I think a number of us feel relatively comfortable that 120 days is probably the optimal time, particularly if you've got limited resources to work out what is actually happening. I don't know how many registries, though, in terms of developing their follow-up data, have actually asked patients about what matters to them. At the end of the day, that's what counts, is what matters to the patient. What does success look like to them? Most of them, I suspect, don't give two hoots if they're in hospital for 7 days or 9 days. What they care about is that they are not in pain, functioning at home with family, integrated into society. So I think when we're talking about follow-up, which is enormously challenging, we need to be collecting the data that actually is meaningful to the patient population that we are there to serve, really.
Paul has a question, comment?
Chris, Paul?
Yeah, hey guys, it's just the last question, then I've got to run. But it's something I keep asking myself about: hip fracture registries, fracture liaison service registries, all of it, right? Project yourself forth to the 31st of December 2029. Where do we want to be? What do we want to have achieved? And I think we really need to think about that. This is the decade of healthy aging, as the UN and WHO has declared. What do we want to do? You know, what can we achieve feasibly in this time frame, and what can we do by 2025 and by 2030? Just going to throw that out to you guys to think, you know, what is achievable based on all this experience that we do have, the brilliant stuff Jackie's done, Chris has done, Anthony's done, Jai Young's done, and other colleagues have done. What can we do for the whole world, and what can we share?
So I think on that note,
Jackie, in the chat, having anticipated that we might struggle to get comments from 100 people in the panel discussion, Chris has built a Google form which allows people to respond to the questions that we've raised about the minimum common data set. It takes a couple of minutes to fill in. It's very simple, but it would be really useful to get input from all of the attendees here and the panelists here who've got such experience of putting the minimum common data set into practice in an economy that we wouldn't recognize in Europe. So if people could provide that sort of information, it'll allow us to pull together the Asia Pacific view in our adaptation of the MCD in the SIG. It's in the
That's
chat.
actually really helpful. That's actually really helpful. When are we good to share that? After?
Yeah, if you can also forward that to me, Anthony. I think you have already forwarded it to me, and I'll cascade it to the attendees of this meeting, and to the national Ffn leads. So you can count on that.
Thank you. That would be really helpful.
Yeah.
Thanks, Anthony and Chris, for a really good session.
Thank you.
Before I ask Erwin to close the meeting, I think we've got a short reaction from Juanita Javier, who's the chair of orthopedics at Manila Philippine General Hospital.
First of all, let me greet everyone. Good afternoon, good morning, or good evening, depending on your local time. First of all, congratulations to the Fragility Fracture Network Regionalization Committee and the Ffn Hip Fracture Audit Special Interest Group, especially for the local organizers headed by Dr. Irwin Pabu for this successful and enlightening pocket meeting. Thank you very much to all the panelists from all over the world. And I am very, very happy to be in the midst of many champions in the proper management of fragility fractures. I'm sure participants from the different countries like the Philippines will come out of this meeting with more ideas on how to proceed. And we are looking forward to more events like this and other activities aiming to further promote awareness and understanding the need for a comprehensive approach to fragility fractures. I am proud to say that in my country, the Philippines, we have found our champions. And we have leading advocates like Dr. Irwin Pabu, Dr. Joseph Lai, and other members of our Department of Orthopedics of the University of the Philippines, Manila. Through their efforts, we have seen the growing interest in fragility fractures in the different parts of the country. And I am proud to claim that my department leads in this growth. So on behalf of the Department of Orthopedics, I would like to convey to the group that the department will continue to push our country in the promotion of orthogeriatrics. This is very much evidenced by our steps to have an orthogeriatric unit going. And we are very proud to note the beginning of a national hip fracture registry in our country. And for a country like ours, this is a major and significant development. We need to have a good grasp of the problem, and the registry will go a long, long way in achieving this. Fragility fractures is a very big problem, and only through a unified and concerted effort will we be able to make a difference. We are very grateful for the kind support and the willingness to share by many experts from the different parts of the world. The problem of fragility fractures is very significant, and I am certain this gives us all the drive to search for the solutions. So once again, good day and stay safe.
Thank you very much, Juanita. That's sentiment echoed by us all. I'm going to hand over to Erwin to close the session. As has already been identified, Erwin, you are a lead and a champion in the Philippines and also in the Asia Pacific region. So thank you very much for putting this, what was a fantastic pocket meeting, together. Over to you to close the session.
Yes, thank you, Dr. Javier and Jackie, and actually to all. Dave is here, and to everyone. Actually, the influence of Ffn is really, I cannot gauge how big it is. From scratch 3 years ago, we were able to sort of initiate programs about the orthogeriatrics and fragility fractures because of the influence of the Ffn. So I'd like to encourage everyone, even from the low to middle income countries, to join the Fragility Fracture Network, because it has worked for us, the Philippines, although we are a country with so many challenges. So it's also possible to other countries. Okay, I think we had a very productive meeting and workshop for today. I hope we were able to enlighten and convince our participants in today's webinar, okay, about the importance of collecting and gathering data in the form of hip fracture registries as a means of improving the way we deliver care to our patients with fragility fractures. So in line with this, I would like to invite you all to join the global Ffn family and support the 2021 Global Congress this coming September 28 and 30. It is a fully virtual event hosted in the Eastern Daylight Time Zone, But this is with excellent plenary talks from a multidisciplinary group of experts around the world. This combined with a pre-Congress regional meeting on the 28th of September, which will be in 3 regions: the Asia Pacific, the European region, and the Latin American region. And we will again be hosting this. No? This is with live events, which will be moved to on-demand status in case that your time zone limits you from joining the live events. So this is with very, very reasonable registration fees. And we always said, if you love what the Ffn has been providing for all of us, all the free materials, all the free webinars and everything, that the registration fees, the meager registration fees, will go a long way, into funding even the less, the emerging economies, the countries with emerging economies. So that's my plea to everybody. Let's at least help the Ffn and register to this global congress. The early bird registration is up to July 30. So let's take this opportunity. Okay. And again, I would like to thank the hip fracture audit special interest group of the Ffn, the Regionalization Committee, the program committee members of the Ffn, and to all the speakers and all the chairs. No, I cannot mention you again. And to the registrars of the Department of Orthopedics, our chief resident, and of course our head of the technical support group, Dr. Bernard Alpuerto, who really did a good job, in helping us in consummating this event. So again, thank you to all of you, and please look forward to many more. There's another pocket meeting webinar on August 14. Okay, this time with the recovery research interest group of the Ffn. So thank you, and stay safe, everybody.